Hi, welcome back to the Leukopak Lady. So as you may know about me, I'm at my best when I'm doing something that nobody else is doing. I look for ways to contribute to the team effort or the industry conversation in different ways from others. And this is also true when it comes to this Leukopak Lady series. I want to bring issues to light that nobody else is focused on. I want to highlight different perspectives than those that I'm hearing, and I want to tie ideas together that don't seem related but can be. And that's where today's topic comes in: cellular starting materials for in vivo therapies. So I hope your interest is piqued, because there is no CSM for in vivo cell therapies, right? You would be technically correct in thinking that, because in vivo therapies are designed to engineer a patient's own immune cells inside their body, turning their body into the manufacturing site for targeted treatments like CAR T cells. And this is in contrast to ex vivo cell therapies, where CSM is collected from patients or healthy donors for use in manufacturing of engineered therapies and then infused into the patients. I want to pause here to give credit for the discussion in this episode to a LinkedIn connection, Ep2-0401. He tagged me in one of his LinkedIn posts expressing concern over how variabilities in patients' immune systems seem to affect their outcomes in vivo therapies. I'll tag Edo's post when I share my LinkedIn post of this video. And that gave me a great opportunity to tie the discussion I've been having on donor qualification and immune status to the in vivo conversation in a way that fits into my expertise of cellular starting materials. So in 2025, many companies are working on in vivo therapies for multiple indications. Some commentators have even declared that these therapies will take the place of ex vivo approaches, given the simplicity of the therapy manufacturing process, the lack of collections needed, scalability, and the potential to increase patient access. And as exciting as that sounds, there are also issues to be worked out, such as immune cell targeting, mitigation of off-target effects and side effects like CRS, and new complexities in vector manufacturing. Another major issue that has come to light from early clinical data is that the response to in vivo therapies varies widely from patient to patient. A recent article in the New England Journal of Medicine showed this in lupus patients, and other studies from companies share similar conclusions. And those of us in the CSM for ex vivo therapy space might have predicted this, because there are studies and anecdotal accounts of variation in patient outcomes from both autologous and allogeneic ex vivo therapies. And the likely culprit here is the variability in the function of the immune cells found within the collected starting material. And the fact that the same thing is happening in vivo therapies strengthens this assessment. So this means even the in vivo therapy developers can't get away from the fact that some patients just have poor cellular starting material, despite the fact that no material was collected and manipulated ex vivo. Those cells still constitute CSM, even though they stay inside the patient's body. This also suggests that the collection process and the ex vivo manufacturing process may have less impact on the clinical outcomes than we originally thought. And that's good news, I think. Cell therapy success comes down to the fitness of the patient's immune cells, full stop. So what can be done? Well, I've been advocating for a long time that the key to better patient outcomes for ex vivo therapies, and specifically allogeneic therapies in my case, is to have better qualified donors to yield better starting material. As well, this applies to autologous therapies and the patient-derived CSM, and now even to in vivo CAR therapies. And we need to have good analytical technologies and ask the right questions to best assess donor and patient immune cell function and identify key characteristics that make someone a good candidate to donate for ex vivo allogeneic cell therapies, or be a good candidate to receive in vivo or autologous ex vivo cell therapies. These analytics include immune cell phenotyping by flow cytometry, cell health and vitality by laser force cytology, and assays to assess metabolic function, cellular proliferation, vector uptake, target killing, and others. In the end, not all of these tests will be needed for every donor or patient, but for now they are all needed to power the correlation between function and therapeutic outcome and identify those key functional attributes. The ability to identify when a patient may respond poorly to a cell therapy will save them the added risk of toxicities and the expense of the therapy, and hopefully help them receive a therapy better matched to them. This is the topic that I'll cover in the next episode, so join me next week for that discussion. It's likely to be controversial, so you won't want to miss it.